Dionne Sinclair. Now, Dionne is an accomplished certified healthcare executive who is currently the Vice President's Clinical Operations and Chief Nursing Executive at the Center of Addiction and Mental Health. A visionary leader with a passion for transformative change and innovation, Dionne has honed her skills in creating a climate that fosters innovation and develops new approaches to achieve strategic outcomes. Throughout her illustrious career, Dionne has been celebrated for her unwavering high energy, strong work ethic, and perpetually positive attitude. This spirit has created an environment of enthusiasm and excellence in all her endeavors. Known for her ability to motivate and inspire others, Dionne is also a sought-after motivational speaker, sharing her valuable insights and experiences to empower individuals within and beyond the healthcare community. Please welcome Dionne Sinclair, who will be speaking to us on myths about opioid addiction in sickle cell disease.
Okay. I speak better from this side. So I have a disclaimer to say I am a registered nurse. I work at the Center for Addictions and Mental Health, but I am not an addiction specialist. Neither am I an addictions researcher, but I do know several that I can introduce you to. Dr. Leslie Buckley, she is world-renowned, and anything you want to know about opioids and addictions, call her, okay? I also want to blame Delaney for me being here. I know him well, and he sent me a message. Oh, there you are. Sent me a message, Dionne, we're having this conference, and we'd like you to come talk, and you know, you work at CAMH, and we'd just love to hear from you. It's like, sure, no problem. And then later I found the topic, it's like, excuse me, say, what, miss? I'm finishing my PhD, so I know that as a nurse, what do we do as nurses? We go with it. We go and we do the research, we find the evidence, and we find the practices. So there are 2 rows of references at the bottom. So next slide. I just have to put that disclaimer out there. I also did this so that if my mom was here, she would also understand this. Because when I go to conferences and people speak over my head, it's like, I'm gonna go look up every word they just said. Okay, so understanding sickle cell disease pain. We just had a great overview. Thank you so much for that. This is like a great segue. Sickle cell disease characterized by severe pain episodes that often begin early in childhood and persist throughout life. That's that key indicator. It persists throughout your life. This pain is frequently described as more intense than post-operative or cancer pain, making effective pain management crucial. And if anyone has ever had cancer pain or even worked with patients who've gone through that, I've looked after cancer units, I've seen that it's excruciating, not pleasant. The role of opioids, primary role is it's a primary treatment option for managing severe pain, but their use is complicated by the opioids crisis and associated stigma. So I'm gonna go into those. So opioids addictions in people with sickle cell disease, it differs in 5 ways. The prevalence of addiction, the unique pain management needs, stigmatization and access issues, complex pain management, and the impact of the opioid crisis. Years ago, there was no crisis. Now, we have a crisis inside of a crisis. I'll just say that. So prevalence. The estimated prevalence of opioid addiction among individuals with sickle cell disease is about 10%, which is similar to the addiction rate among other chronic pain sufferers. This is United States, but you can extrapolate to Canada. It's around the same. And so here's one of those myths. The challenge is the misconception that sickle cell disease patients are more prone to addiction. They're not. So if you take anything away from right now, they are not more prone to addiction, same as the population. Help? Okay. Next slide, please. I can't do 2 things. Put that down. All right, so the unique pain management needs. Sickle cell patients, they experience severe and unique pain episodes, often beginning in childhood. We said that earlier. But this pain is frequently described as more intense than postoperative, and it necessitating effective management with the opioids. And the chronic nature and intensity of the pain requires long-term opioid use, which leads to physiological dependence, not necessarily addictions. And I know later we're going to talk about dependence versus addictions. So that's the one takeaway. Just the bottom slide, there's a repeat at the top. And stigmatization and access. People with sickle cell disorder, they often face stigma and are unfairly labeled as drug seekers when they seek pain relief. That leads to inadequate pain management and reduced access to necessary opioids. And the stigmatization is exacerbated by racial bias, as most patients predominantly are individuals from African descent. And I just have to say, it's not just sickle cell disease patients, because personally, even as a registered nurse, and I was a director at the time, I had a bowel obstruction. Didn't know it. I had this severe gut pain. Went to Emerge, and I was offered Percocet to go away. And it's like, I'm not a drug seeker. I'm actually a nurse, and I'm in severe pain, and I know I need something. And I was looked on, and people were whispering in the corner, and I projectile vomited across the room, and they go, oh, maybe something else is happening. I was in surgery in less than 3 hours for a bowel obstruction. So stigmatization is real, and you're black, you're brown, you go to Emerge, and you need to be well informed to advocate for yourself. Does that make sense? Okay. So complex pain mechanisms. The pain associated with sickle cell disorder is complex, influenced by multiple mechanisms, including genetic factors, which can affect how the individual experiences pain. The complexity requires a nuanced approach to pain management that goes beyond standard treatment. Now, in my family, we don't have high pain tolerance. Seriously, if anybody's ever had their hair combed, I'm one of those sensitive head people. Yeah, okay. If you're in my neighborhood, you'd hear me. Like, no, I don't have much pain tolerance, but I don't know about your family, mine. So genetics, it does have effect. The effect of opioid crisis, though, the crisis has heightened fears of addictions and overdose, leading to stricter regulations and reduced availability for sickle cell patients. And the two things you need to take away with the crisis: regulations are strict. Availability is, doctors are afraid to prescribe, or they won't prescribe that much because, again, some overprescribed in other circumstances. And you are experiencing pain, you need it. However, it's like, oh, I don't know, because there's so many people out there that are addicted, and it's like, but that's not me. I actually have something I need it for. So this has forced many patients to seek care in emergency rooms where, again, they may be stigmatized and inadequately treated, which is a shame. So we actually, did you guys catch those common myths? They're back here again. And the first one is opioid addiction is inevitable. Yes or no? It's no. The answer is no. Okay. We went over that. Okay. The second myth, opioid use equals substance abuse. No or no? Okay. All right. You know, we're always teaching nurses. All right. So next slide. The consequences of the myths and misconception, really the one thing you need to take away, it's increased suffering. Those myths and misconceptions increase the suffering of sickle cell disease patients. Fear of addictions and overdose lead to stricter regulations, as we mentioned before. It limits your access for sickle cell patients, and it increases suffering, which no one wants anyone they love, anyone they care about, anyone they know or even your patients to suffer. The racial disparities, Black, African American, African Canadian patients with sickle cell disorders are particularly affected by these myths, facing additional barriers due to biases. And one thing I have to say, full disclosure, we all have biases. We all do have biases. Nobody is immune from having those biases. It's just you go for care. You could be the doctor, but you're Black, unless you have it tattooed on your chest, you'll face discrimination and you'll face that judgment of, oh, you must be here just seeking drugs, which is a shame, but it happened. And because it happened to me, I know it might have happened to somebody in this room. Okay. So strategies to dispel the myth. Two things, education and awareness. That's what we're doing right now, but maybe some of the people who need to hear this aren't even in the room. That's usually what happens. Patient-centered approaches. So educating healthcare providers and the public about the realities of opioid use in sickle cell disorder can help reduce the stigma and improve patient care. And emphasizing individualized treatment plans that consider the unique pain experience of patients can help balance the benefits and the risk of opioids. We have alternative pain management strategies. These are non-opioid treatments, exploring the non-opioid pain relief options such as meditation, acupuncture, and non-drug therapies can provide additional supports. I'm not advocating acupuncture or meditation, but I do know for me meditation works. I've never tried acupuncture. Anybody in here? Okay, and if it works, absolutely. Go for those non-opioid treatments that do work for you. Research and innovation, continued research into the mechanisms of sickle cell disorder pain, and the development of the new pain management strategies are essential for improving patient outcomes. There is a problem. There are money out there for research in cancer, for Alzheimer's, dementia, everything. I don't see any researcher saying, oh, please give me some money for research for sickle cell. And that's where we need to be advocates, because there is money out there for research, but we also need researchers. So if anybody here is going back to school, doing a PhD, doing a thesis, here's a topic. I'm just putting it out there. In conclusion, I know my time's up. Next slide. Overall, while the risks of opioid addiction in patients, it's not higher than the general population, the unique challenges they face in managing their pain highlights the need for tailored and compassionate care, and addressing the myths about opioid addictions in sickle cell disease involves a multifaceted approach that includes education, patient-centered care, and the exploration of alternative pain management strategies. And by dispelling the myths, healthcare providers can better support sickle cell disease patients in managing their pain effectively and safely. Next slide, next slide, next slide. Thank you.
Thank you so much for that, Dionne. And now we welcome our third speaker, Serena Thompson. Serena lives with sickle cell disease, and after experiencing years of humiliation, misunderstanding, isolation in schools, hospitals, and at her places of employment, Serena became engaged in the sickle cell community as an advocate by joining committees and organizations championing for patient-centered care. Serena's main focus is advocacy and spreading awareness through information sessions such as conferences, symposiums, seminars, and panel discussions by collaborating with educational institutions, hospitals, community organizations, and media such as radio and television. Alongside Serena's patient advocacy in the community, she recently served as the interim president of Sickle Cell Association of Ontario, a member of the Minister's Patient and Family Advisory Council, Healthy Debate Committee, Medical Doctors Admissions, and was past co-chair of Ontario's Health Sickle Cell Disease Quality Standard Advisory Committee, to name a few. Serena is now serving on Healthcare Excellence Canada, UHNEG's Sickle Cell Working Group, and as a patient partner with the Institute of Genetics. Please welcome Serena Thompson. Yeah.
Hello? Okay. Hi, everyone. Good after. It's still afternoon, right? Okay. Took me an hour to get here, all the way from Scarborough. But hi, everyone. Thank you for being here. So I'm going to be speaking on, IV versus oral medication and which one is more addictive than the other, or what my experience is. So if you really think of it, medicine are chemicals and compounds used to cure, halt, or prevent disease, ease symptoms, or help in the diagnosis of illness. So let's talk about the actual positive side of medicine. The benefits of medicine are the helpful effects you get, such as easing pain, controlling blood sugar, lowering blood pressure, or curing an infection. I just got those wonderful little quotes from Google, so just letting you know. Okay, so my experience with opioid administration. So for me, my story is not typical. Obviously, you've known that everybody is different. Everyone reacts to medication different. Everyone deals with medication different, perceives it differently. So I actually do not take opioids at the very beginning on the onset of a crisis. Because usually for me, it doesn't come on like really hard. It comes on suddenly, but it's just maybe not as intense as it will be later on if I leave it. So what I do is, and then on top of that, I don't like the side effects, the slight side effects, like anything to do with opioids, and also the stigma. So for me, I take a holistic approach. I try to take a holistic approach at the beginning, which is, using a warm compress. Usually it's my shoulder or elbows or my knees. So I put a warm compress in the area, take a hot shower, a hot bath, and then maybe also a combination of some meds, but ibuprofen and acetaminophen to start. So if the pain is unbearable now, then for me, I guess at that time, it might take, it will happen throughout the day. So say I get sick in the morning, and then in the afternoon, it's not going away. So what I do is try to maybe take one of my opioids medicine at home. It would be hydromorphone. It used to be morphine, but that doesn't work on me anymore. So we had to go to hydromorphone. So usually if the pain is unbearable, by then I'm going to the ER, and by then I'm like, okay, my pain is like really severe at that time, if we're going into the ER, most of the time our pain is at the 10, only because I guess we're just trying our best to take care of it at home. Don't want to really don't want to deal with the ER, do not want to deal with, staff that may not even know a lot about what to do when we come in with sickle cell crisis. So what I do, by the time I do arrive, I'm asking for opioids where I feel it can be safely administered and monitored, along with my advocacy as well, because I know exactly what works for me, And I don't mind suggestions as well for pain management, but for me, it's like what really works for me, I'd let them know at the very beginning just to see if that can work and take care of the pain. I actually prefer IV over oral. And that is because, as you saw before, it hits, the pain right away. By then, I can finally relax and just let the medication work on through the pain. Because one thing it does, the pain will have me tense, and that actually brings on more crisis pain, being tense and having anxiety. And then it helps me, so the IV is better for me. It helps me calm down and not to tense up during a crisis, which is a trigger or prolongs it. So one thing about the IV as well, I don't like the pump. I saw the PCA pump, I don't like it. I seem to do better when it's IV drip, I guess that's what you call it. I do better that way because the first dose, it usually works. I feel it, it works, I'm calm. I like being in a dark area, lights off, quiet room, and so forth. And so, and for me, so when we see the statistics about how many, sickle cell patients are really addicted, it's extremely low. It's extremely low in Canada. And, this is something that we want to get past, especially going into the ER. We want to get past the whole, oh, didn't you just feel that? Oh, you must have felt that. Oh, we just gave you, a high dose, this, that. But they have to understand that we have been having this crisis. We live with sickle cells, so we've been having pain, we've been having crisis all our life. We know the degree of pain and what kind of medication would work with it and so forth. So that is what I wanted to mention. And then the last part, just showing you a little personal, part of my life. And what I wanted to do is just read this poem. That's not on the screen, so this can stay. But what I wanted to do is read a poem for you guys. If you could maybe listen to it with your eyes closed, and that way you will understand what I'm talking about. I am a human being. I live with pain every single day of the year. Diagnosing me and my parents at the time of birth devastated them. I would be spending the rest of my days in pain. Sick Kids Hospital became my home, my second home as a child, and Scarborough Grace Hospital became my second home as an adult. That saved me. Why? Because of a protocol. My pain is so real, and the protocol helped advocate for me. IV oxygen pain meds. IV oxygen and pain meds sound simple, but yet so challenging to receive basic care. Oh wait, is it because I'm not dressed up? Don't I look approachable at 4 a.m. in the morning? Sorry, let me brush my hair. I apologize for looking like I just rolled out of bed. I don't want to be here, but the pain is too much. The stress, the anxiety. I'm here because I need help. Please, will you help me? I've been here for hours. It's very unusual. You don't look like you're in pain. That's because I'm not used to it. That's because I'm used to it, but not the intensity. Please don't think I'm a drug seeker. Please don't think I'm a drug seeker. Do you have a protocol? Can you help? It would be nice to see a change during my life since it's been over 114 years this disease was discovered. Yes, that was my boyfriend who dropped me off, but the pain was too much for him to bear witness to. So I'm here alone, fending for myself, hoping someone understands. What am I going to tell work again? I hope they understand me this time. I don't want to be let go again. School is going to fail me because my paper is due. I don't want to start the semester over again. Oh no, rent is due next week and my finances are not enough. I can't stay here. I must go back to work. Daycare will never understand, so I will have to keep my daughter enrolled. Now I have to call my sister to help, and she has work. I feel lonely. I feel like I have no control. Maybe it's best I speak to a social worker. Empathy is all I ask from you. I am a human being. And that's it.
Thank you so much, Serena. And thanks to all the panelists, the speakers who shared this morning. At this time, we'll open the floor to any questions for any of our speakers.
Yesterday, hearing the story from Fitzanne, and again today from Serena, it just really touched me. But what I wanted to say was, as a nurse, I work at Toronto General, and we have what we're talking about, patients, the midst of opioid addiction and things like that. But there are times when we see, and we call them frequent flyer, is a handful of patients who come in, sickle cell patients. And the behaviors of these patients are what unfortunately blocks the care that someone like Fitzanne or Serena would come into the hospital. There are, for instance, they will tell you, well, we want you, if the medication is ordered Q2, PRN, they want it, just bring it. But we can't bring it like that. You have to ask for it. And in asking for it, we're assessing to see whether your respirations are low, that sort of thing. There are times when you've, like Serena was saying, intravenous, how the medication is given, and you'll hang it, and then they'll go into the bathroom, and then within 5 minutes, they come out of the bathroom, the bag is empty. Not just the medication bag, but the other bag as well. So that's them bolusing themselves. So we're struggling even within even within the care we're trying to provide for that small group of patients, but unfortunately, with the struggles we have with them, I know I can see how it makes it difficult to care for someone like Fitzanne and Serena. And within our organization, we're having meetings trying to find the best way to even care for that small group of patients.
Appreciate that perspective, yeah.
So hi, it's Dionne. I'm also a registered nurse, and I understand and hear you. My perspective, and I know it is possible, when you holistically meet with your patients, speak with them, create a plan, and you can have individualized protocols in every single emerge with every single name, because now we have electronic patient records. So if I had sickle cell disease, it would be the Dionne Sinclair plan. Dionne comes in, you've checked my health card, you know it's me. Here's the plan. This is what we do. And the first one is listen to the patient. If I'm in pain and this is what starts off, IV works best, don't give me a pump, I like the drip. You have to do those things because at the end of the day, you are the content matter expert when it comes to what you need. And there will be those one-offs, but for the most part, when you live with it 24/7, you absolutely have to listen to patients and the family members, because these parents, they know their kids better than you'll ever think you know the kids. So don't even just listen to the parents. I fight with doctors and other staff members that if you don't listen to the patient, then we're not treating them properly. We're not treating them how they need to be treated. You say that you don't take basic opioids, you're on hydromorphone now because you've been in pain all your life and you know you needed a different type. So it's super important that every single patient have their own individualized protocol. It's customization, the care. We are gonna get there in organizations for each patient. And then the ones that come in, go in the bathroom, bolus themselves, they'll have a customized protocol as well. Maybe somebody follows them in there, or maybe there's something else, but for each individual, set up the protocol. So when you come in, we know exactly, dark room, by yourself, IV drip, and this much, and just, it can work. I know the system can work. And well, a few people in here know I'm going after a CEO position just so I can put those in place where I work. All right, thank you.
Thank you. I have a question here.
Thank you so much. So you talked earlier about stigma, and I think just to follow on the earlier question, is there any data to support where the stigma is coming from? Because it seems like it's not all patients that are doing this or that are abusing the opioids, if you will. So have we tried to understand where the stigma is coming from and how we can use that information to educate people to say, well, this is not the norm. The fact that people are, maybe seeking help or present to the hospital, but they don't look like they're in pain, but are telling you they're in pain, you should listen to them. Is there data to sort of maybe help inform people who are misinformed? And how can we use that to really educate them adequately?
Thank you for that question. It's a valid question. Because the population with sickle cell disease are mostly African, Caribbean, but Black, stigma comes from racism and white supremacy. Because if your name was John Smith, blonde hair, blue eyes, and you're in pain, it's like, come here, let's get you in a room right away and let's assess you and take care of you. I'm not saying it's that exact, but in emergency rooms all over, if you're indigenous or if you're Black, there is research, there is data to show that their treatment is worse than anyone else who walks in that emergency room. We've got data. I work at CAMH. Oh, this is being recorded, so I won't share that data, but it is difficult. And what we're doing right now, our emergency room manager, he's Black. Once upon a time, the population in Emerge, it was like almost 90% white nurses. Now we have 19 different languages because he intentionally went out and hired staff that represented the population that's coming in. So our data is better, the stigma is down. The chief nurse at CAMH, we have a very diverse nursing population, but it's not just at the front line. Managers, directors, director of nursing practice, her name is Serena Chambers, Jamaican, phenomenal. And when you diversify the caregivers and the decision makers, the ones who do the policies, the ones who spend the money, that's how you're gonna dispel stigma, because some people, they're brought up in that racist system, and in their head, the assumptions are made, the biases are made, and it's just, they see you coming in, oh, here's another, I was considered a drug dealer. No, I wasn't dressed up. I was in jeans and a t-shirt. I was throwing up. I was in pain, and I was thought of as a drug dealer. Nothing from that was true. However, people have their biases, unconscious or conscious. They're gonna have those biases, so you have to change the system, change who the decision makers are, and that's how we're changing it.
All right, thank you, Dionne. We have one question on this side.
I am glad I heard about the individualized plan that you spoke about. So those plans, families should go and see their doctor before a crisis happens and set this up. That's what it means? Okay, thank you.
Yeah, it's better to get to know your patient ahead of time when they're normal, when they're not sick. It's better to understand their personality. You get to understand their life, where they're coming from, if they're dealing with stress, because stress is that #1 trigger, and then ask that patient, okay, what usually works for you at home when you're dealing with pain? What works for you when you come into the ER? What really works for you then? And work out that treatment plan, because it's something that the nurses can and the doctors can follow even before you show up. You know, they can start, because this is what happened to me. I was in a different hospital. I used to go to a different hospital in Scarborough all the time, and they had a protocol for me. I didn't know about it. I just knew that there was a protocol for me. They knew right away what to give me and all this stuff, and I was like, what is happening here? And I realized my doctor, who knows me and happened to end up being the chief of staff for the ER, he put in place the protocol and made sure that anytime somebody comes in, treat them right away, call him later, kind of thing. And he would show up when I'm feeling better. So he didn't have to do much. And so that was really good in getting that pain control, and then also eliminating having to be admitted.
I just want to add something for the parents in the room or for patients in the room. They're called medical directives. So if you can talk to your physician, talk to the emergency, say, I need a protocol, a directive, and it would be there on your file. You have a care plan, and it's usually an interdisciplinary care plan, but if your care plan is already laid out, so when you come in, they can start treating right away with that directive. The doctor doesn't have to be there or assess you. The directive gets implemented right away. So if you don't have one, I would recommend speaking to your provider, whoever your primary care provider is, either a nurse practitioner, physician, and get that medical directive in place, get your individual protocol in place. So while you're well, they know, and so when you come in, they can act on it right away.
Okay, thank you so much. Let's do one more question.
Hi, thank you to all the panelists. Just one quick comment and a question for you, Serena. So I'm a fairly new family physician grad, and just a comment on the stigma and the, thanks. On the stigma and the issues around opioid prescribing. I feel like there was a bit of a hidden curriculum as a resident around opioids are bad and we've overprescribed them and be very careful. I've worked in settings where it's like I wasn't even allowed to, like in urgent care and walk-in clinics, you just don't prescribe opioids. Someone could come in with sickle cell, I have to send you to emerge. And so, you know, hearing from your perspective and reading some literature, talking to patients, there really is a balance. Like we see there's this 10% number, which I actually wasn't aware of. And there's people that genuinely need them. And I think we've swung a little bit in the wrong direction, and we kind of have to come back to the middle. And then my question for you, Serena, is a lot of this maybe doesn't apply to a primary care setting, but I'm just wondering, as a patient, what has been helpful from family doctors or nurse practitioners, and how can we better support patients with their pain management?
Thank you for the question. Congratulations. So what is helpful for me? Well, the family, I wish family doctors were more involved with sickle cell, and because for the longest time, I would try to get my family doctor to come to conferences and stuff like that, and she'd be like, oh, I know enough, or something like that. I'm like, okay, but I'm always learning. So you could be doing the same thing, and it could enhance your practice as well, with just, you know, keeping up to date with what's going on. So I find a lot of family doctors aren't really involved with the community practices and the community involvement. That's one thing that I want to see different. And also in getting the community as well, the community, like agencies and stuff like that, more involved, like actually, because one thing we really need a day clinic. That's the one thing we need. And if people would push for that, like somewhere where we can go for day treatment, like, I don't want to use that word, but just like if somebody went for treatment and they're at home, because this is happening right now, somebody went for treatment, they're at home recovering, but need medication, need a little bit more fluids and a little bit more help and monitoring. So something like that. She's not trying to be admitted, but at least, you know, somewhere that they can get taken care of for the day, and then they're gone about their business after that. Because really and truly, we do not want to be in the hospital. We don't want to have to deal with everything going on and stuff like the guessing game or the, you know, the power shift and all that stuff. You know, we just want to be able to just take care of it at home. But yes, definitely the family doctors, I want to see them more involved. Yeah.
All right, thank you so much. Unfortunately, that's all the time we have for this session. I just want to thank our speakers once more. Thank you so much. Yeah. Please remember to kindly provide us with some feedback on how the session was for you today. At this time, we will break for lunch. Yeah, we will be breaking for lunch, and I hope to see you at the next plenary session. Thanks. Take care. Bye.